Today I'm going to talk about a comparison of 4 existing dementia palliative care services using the REAIM framework. So I'm just briefly going to present the case for dementia palliative care and why I think it's important. So firstly, dementia is a life-limiting illness and the median survival post-diagnosis is just 4.5 years. Dementia is the 7th leading cause of death worldwide according to the WHO figures. Last year in England and Wales it was actually the leading cause of death. And the most recent Irish figures I could find were from 2018, where it was the 4th highest leading cause of death. And while there's brilliant advances in dementia treatment coming up, hopefully very soon, there's still no current curative treatment. So all treatment in dementia is essentially palliative. But we know that people with dementia are less likely to be referred to specialist palliative care than cancer patients, despite having a similar end-of-life burden. So that might be for many different reasons. The prognosis is quite, it's a slow disease progression with occasional remission and a lot of comorbidities. Symptoms include things like the cognitive impairment, communication difficulties, the non-cognitive symptoms of dementia, those that were previously called the behavioural and psychological symptoms. There's a lack of patient voice, which impedes shared decision making, and there's still a lot of stigma around dementia, unfortunately. So data from England and Wales quite recently has shown that the overall demand for palliative care is expected to increase by up to 42.4% over the next 20 years. And the data also show that dementia was the main driver of that increase. So it's therefore really important that we develop models of care to guide service delivery. So I suppose we can have the most efficient use of existing resources. So with that in mind, the model for dementia palliative care project was developed. So this was quite a large-scale project that was ongoing over 5 years. And the aim of this overall project was to develop a model mapping out what services, assessments and treatments a person living with dementia might need so that the health system can better organise their care. And it was a model focused on people living with dementia living at home in the community. So you can see in that graphic there's lots of different elements of that larger 5-year project. So today I'm just going to focus in on one part, which was the site visits to exemplary dementia palliative care services. Okay, so within the site visits, our aim was to examine in-depth exemplary dementia palliative care services for people who are living with dementia at home in the community. So to identify the 4 services which we ended up with, we had a long list of 55 services that were identified across Ireland, Northern Ireland, England, Wales and Scotland. So we had conducted a survey of experts in dementia and palliative care and asked them to identify any kind of exemplary services in their areas. So we whittled that down to a short list and finally just 4 services, which I'll go to in a minute. We designed a cross-sectional mixed method study. So we conducted interviews, surveys with staff and service users where we could. We also collected routine data and quality reports. And so we analysed the data using thematic analysis and descriptive statistics. And we also applied the REAIM framework to kind of compare the 4 services. So REAIM stands for Reach, Effectiveness, Adoption, Implementation and Maintenance. And I suppose it's a framework not to just look at why a service, what elements of a service make it effective, but also how can it be translated to another setting and how can it be made sustainable. Okay, so I'm just going to very briefly pick out a few interesting findings from across those 5 domains from the REACH framework. So looking first at REACH, briefly I'll just give you an overview of the services for a little bit of context. So we had 4 services from 4 different regions. So the first service was led by specialist palliative care out of a hospice. What was particularly interesting about this service, it was co-located with a hospital. So there's kind of a good history of them getting a lot of referrals of older people with dementia from the hospital. And they had also then upskilled their community specialist palliative care team in dementia care. So they were able to facilitate some more dementia care at home. The next service looked completely different then. That was led by Psychiatry of Old Age. And it was an advanced dementia care service. It was called to support people with dementia in the last year of life to stay living at home. And it was run by the consultant psychiatrist of old age and a mental health nurse. The third service then was primary care led. It was 6 dementia nurses who were providing very general support to people living with dementia and their families in the community, but they just had a really particular palliative care ethos and introduced those kind of ideas of palliative care and advanced care planning very early. And it was found then that they had kind of later, maybe better end-of-life outcomes. And then the final service we looked at was another one led by specialist palliative care operating from a hospice. And again, they just had a really good ethos historically of including people and patients with dementia in their services. Okay, so the services, as you can see, the 4 services looked really, really different. So we tried to kind of draw what were the commonalities and what were the differences across them. So in terms of their reach, 2 of the services did only focus on people with advanced dementia who were nearing the end of life, whereas the other 2 accepted people with dementia of any stage. Other than that, all 4 services accepted any person with dementia based on their care needs, so there's no restrictions around their age, gender, ethnicity, or dementia subtype. One factor impeding reach is one of the services that was in a larger city felt that people with dementia coming from minority ethnic communities were very much underrepresented in their service. Other than that, caseloads really varied across the 4 services. Those kind of dementia-led services that were based in the community had a lot more flexibility about their caseloads. So, they could take on more cases if they felt it was families who were earlier in their diagnosis, who didn't need as intense support, whereas obviously the hospice services were limited by number of beds and staff. And just one example of how one of the services increased their reach. So initially, to be referred to the dementia palliative care service, people needed a diagnosis of dementia, whereas they found a lot of people weren't diagnosed and just were living with memory problems. So they then introduced a new assessment tool to allow GPs to formally diagnose and refer to their service. So looking at adoption then, so how well service staff kind of accept the service activities. So the staff within the services, adoption was really, really high. It was really clear from speaking with them that staff across all these services were really passionate about the dementia palliative care they were providing. External adoption then varied a little bit more. So for example, the service that was a dementia palliative care service but led by psychiatry of old age found that some people weren't referring to them because they weren't seen as an end-of-life service because they didn't have specialist palliative care in their title. So that was something they had to address. And just something else that was noted is that GPs were particularly poor referrers across the services, except for that service which was primary care led. And things then that increased adoption were electronic forms, so like This Is Me forms and EPACs. And again, they were more common in the England, Wales kind of services. Okay, looking at effectiveness then. So where we could collect data from service users, we saw that service users were really, really satisfied with the level of care. And in fact, all of them said that the services they had gotten had benefited them and their family. People with dementia were typically perceived to have had better outcomes when they were at home for end of life, but that was, maybe more in comparison to a nursing home setting. So effective end-of-life care at home required close working with GPs, public health nurses or district nurses for equipment such as syringe drivers, and out-of-hours support being provided was really important to facilitate that as well. Whereas the things that were particular to the hospice environment were things like being able to personalise the environment. And then other factors that were relating to the effectiveness of services across all 4 services included being able to have an early advanced care plan and good care coordination, really trusting relationships between families and staff, and the ability to provide personalised activities that were kind of personalised to the person with dementia and their interests. Okay, so looking at implementation then, how the services were implemented. So while they all provided very similar activities, they were, their makeup was really, really different. So for example, Service B was run by just a part-time consultant and 2 part-time nurses. Service C was run by 6 part-time nurses. And then the specialist palliative care-led services had much greater staff numbers, but obviously they were serving a wider population than just those with dementia. We could only get cost kind of data from one of the services, but it suggested, a significant cost saving. So £700,000 cost saving across a case series of 14 patients that they helped to die at home. We looked also at slippage, so what might cause a service to not be able to meet its stated activities. So things like, it's no surprise, but lack of funding meant that some services couldn't offer 24/7 phone support, and that was something that was really, really valued by families. Having insufficient formal home care and respite hours impeded that informal home care, for family members to provide care at home. And increasing service numbers across most of the services meant that bereavement visits were no longer automatic to everyone in a service where they had been kind of just followed up with absolutely everyone. They had to limit that then because the numbers were increasing so much to just those who they felt kind of had particularly complex grief. And finally, maintenance then. So all 4 of the services were initially commissioned by either charity or health service organisations as time-limited or pilot projects, but all were either time extended in terms of being able to offer additional activities, or extended to neighbouring or additional regions. And I suppose that just kind of shows how successful the services were, that they were able to ask for and fight for and get that extra funding to expand their activities. And then, just to conclude, so, as we kind of, I very briefly introduced there, we looked at 4 dementia palliative care services before that looked really, really, really different. So what we concluded is the structure of future dementia palliative care services in terms of staff composition, etc., does not need to be prescriptive, as different structures have proven effective. So whether the services we looked at were dementia-led or specialist palliative care-led, their efficacy was associated with providing a range of key dementia palliative care activities and being able to implement them effectively. These key activities might include things like advanced care planning, care coordination, personalised activities, and out-of-hours support. And adoption can be increased by awareness raising within the referrers in that jurisdiction and e-referral packs. So overall, the data collected really strongly suggests that the benefits of the dementia palliative care services to the person with dementia and to their families. And just to say finally, this was a really brief kind of overview of the project. So if you're interested in the nitty-gritty detail of it, we do have a paper published that goes into it in all of its detail. So I'd just like to acknowledge the project team, our funders, and all the participants who took part, and I'm happy to take any questions.